Welcome, everyone. My name is John Martin. I'm the Chief Medical Officer of Butterfly Network and a vascular surgeon by trade. And I'm joined by my good colleague, Mike Stone, who will introduce himself shortly. But I wanted to explain to you what we're actually doing here this evening. And this doesn't really look much like the doctor's lounge we all grew up with. Now, I'm an old dog, been around a long time, and the doctor's lounge was a place that we all used to meet. We would discuss cases. We would share ideas on patient management. We'd learn from each other. We'd eat stale donuts and bad coffee. And it was a place where knowledge was exchanged and was a critically important part of learning medicine, of taking better care of patients. And so as Mike and I actually thought through the way the world has evolved, and candidly, the way he and I are now separated by opposite ends of the country, we both long for the days where we actually met inside hospitals, met with primary care doctors and everybody that came in. And so what we decided we try to do was kind of leverage technology and recreate the doctor's lounge virtually. So the goal of this is not necessarily structured, because when you walked into a doctor's lounge, you never knew who you were going to meet or what you were going to talk about. We have some ideas we'll share with you, but this is really meant to be an exchange, a virtual doctor's lounge where physicians from all different specialties, and we invite nurses and any healthcare professional to be part of this, where we can have the kind of dialogue where we learn from each other, we share great ideas, we learn from each other's good experiences and bad, so that we can all take better care of patients. And so I welcome you all. We encourage you all to join others and to have your friends and your colleagues join us in the future. We look forward to your active participation here during this. And I think we'll find this to be very interesting. I've been looking forward to this for quite some time, and Mike and I have worked together nicely across the country. We look forward to having the same kind of dialogue Mike and I have regularly with you tonight. And so Mike, I'll turn it over to you, and let's see what kind of people have shown up in the doctor's lounge tonight.
Yeah, awesome. Thanks, John, and thanks everybody for showing up, and welcome to people who are tuning in right now. So I'm an emergency physician by training, and I am VP of Education and Sonography here at Butterfly. And this is, we've run some image review sessions in the past where we talk through some interesting cases and take submissions from the Butterfly community. And we did get some great cases sent in that we'll take a look at some images. But we really want to take this a little bit further into making it more of a dialogue. I'm not quite as old of a dog as you, John, but I do remember the days of the physical doctor's lounge. My first job moonlighting in an emergency department had a very old school doctor's lounge with, hot chocolate mix and stale coffee. And you'd go in there and you would have these really phenomenal conversations about an interesting presentation that one of your colleagues had, or somebody coming out of the OR with a great case. And that's really the purpose here, is just to encourage that kind of discussion, look through some interesting ultrasound stuff. We're going to demo something today I'm a little bit excited about that I haven't told you about, John, which is some live scanning. We'll see how that comes across. And I would just...
The audience can teach you how to scan.
I could use some pointers, as always. If people who are participating want to ask questions or have things on their mind or interesting cases that have come up for them that they want to pipe in and have us discuss, just go ahead and post into the chat or into the Q&A, and one of us or both of us will keep an eye on it over the course of the hour, and we'll see what comes up. So I did put some cases together in a presentation, just given that people submitted some cool ones. So let me go ahead and share that. This is a case from a primary care doc who sent this case in. Patient presented to them with some dorsal foot pain and erythema over the dorsum of the foot. And they'd actually already been evaluated by the primary care doc, and they had sent them for an MRI. Patient had long-standing bilateral peripheral edema to the point where the exam was really challenging and not that revealing. They sent them for an MRI. And the MRI suggested that there was tenosynovitis of the extensor digitorum longus. So that was the concern when the patient came back to the office after having this MRI done. And they went ahead and performed an ultrasound. And we're looking at a transverse view of the tendon here. Tendons are hyperechoic, they're bright, they're fibrillar. And we can see that there's this anechoic collection around the tendon, inside the tendon sheath surrounding the tendon. We've got some dilated veins up here in the near field, And this is the transverse view, pretty much what you'd expect for somebody with tenosynovitis, whether flexor tenosynovitis that we are always concerned about in the emergency department for hand injuries, because FTS can be quite debilitating, or extensor tenosynovitis, which can be common as well. If you're looking at something in ultrasound, you haven't really seen it unless you've seen it in two planes. So we're going to go ahead and do what the provider did, which is turn into a longitudinal plane. We're looking at the tendon here transversely. And here's the longitudinal image, and there's some really cool stuff happening here. So here we really appreciate this fibrillar nature of the tendon, right? You can see just all the fibers of the tendon running longitudinally. We've got this fluid collection, this anechoic focus here and here surrounding the tendon within the tendon sheath. And then you can see there's this little nodular focus on the superficial aspect of the tendon. And as they're moving the toes through a range of motion, we're seeing the tendon move. And this is dynamic ultrasound. This is one of the coolest things about musculoskeletal ultrasound is you're not, as opposed to MRI, which is, I think in a lot of our minds, considered the gold standard for tendon and ligament injuries and pathologies. MRI is not dynamic. For anyone who's ever been in an MRI, hold still, put the headphones on, try not to get too claustrophobic, and don't move. And on the other hand, with ultrasound, in contrast, you can go ahead and actually look at a structure and image it through a range of motion. And that dynamic aspect to ultrasound is really revealing at times. In this case, really revealing because there's a nodule on the tendon itself that's probably just fibrous, but is impinging on the retinaculum as they go ahead and move this through its range of motion, and is probably what's leading to this tenosynovitis. So really cool extra information gained from just doing an ultrasound even after the MRI was performed because of its dynamic nature. And then this doc really kind of put the cherry on top and then used ultrasound for procedural guidance. And here we can see we're back in a transverse view. And I apologize, my cursor doesn't seem to want to show up if I'm not playing a video, but you can see that there's the needle is in place starting at about 3 clicks down, so about 6 millimeters from the skin surface, entering from the right side of the screen, that hyperechoic line that's going into the tendon sheath. And they're doing an injection here of some anesthetic and corticosteroid. And the plan is to see how the patient does over the next few weeks. And hopefully next time we do Doctor's Lounge, we'll have some follow-up on this case. I'll reach out to the doc who submitted it and see if they're improving. If not, the plan is going to be to actually consider going in and removing the nodule from the tendon itself to try and free up the range of motion and stop that impingement that's going on with range of motion.
Hey, Mike, I guess let's take the flip side that this was Mike Stone in the emergency room. Would you have gotten an MRI following this ultrasound, or would you have stopped right there, done this entire procedure, and not gotten an MRI?
Yeah, I wouldn't have gotten an, I mean, there are certainly cases where I'll refer people for MRI after musculoskeletal ultrasound. A good example for me would be something like a partial supraspinatus tear in the shoulder. If I feel confident that's what I'm seeing, you get more information about the remainder of the joint. And I consider myself facile with musculoskeletal ultrasound, but not an expert. So I would probably refer that patient, given the potential morbidity that comes from a poorly healed shoulder, in for an MRI as an outpatient. Something like this, a dorsal injection or tenosynovitis, or diagnosing impingement in the shoulder, which you can do really well with ultrasound as well. I don't. My practice would not be to refer that patient for a follow-up study. I think it's extra time and expense, and is unlikely to change the management plan for me.
I think this is a really cool example, and something actually I didn't know till you taught me was, and we've seen the same experience from the professional sports franchise we're working with, is the value of ultrasound in a dynamic nature. Because everybody's reflex is go get an MRI, go get an MRI, but it's a static study and you don't see this. And so, like, for instance, ankle sprains, that's the other one we learned from the NBA players. You don't know whether it's stable or unstable, but you can do an ultrasound and actually see the movement, and it makes a huge difference. So I think one of the other things that we've learned at Butterfly, the MSK stuff is huge. I didn't really expect that, but there's a lot of MSK ultrasound that a lot of different specialties are doing. So it's a great focus for people to learn. It has great value for the patients you see, because a lot of people are hurting a lot of things, and old athletes like you and me, we don't bounce anymore. We don't flex anymore. We hurt a lot of things. This is a great case.
Well, I'm really looking forward to not breaking or tearing something in 2021. That's my aspirational goal for the year. Having I've been through a couple of surgeries in the last few years, broken some ribs, and ultrasound for MSK. Yeah, I mean, not just for tendons and ligaments, right? It's phenomenal for effusions. It's phenomenal for joint injections and aspirations of joints that you may not feel comfortable doing by landmark, like a hip or a shoulder, and then for sure around the dynamic aspect for things like widening of the syndesmosis. If you've got a sprain, is this an unstable sprain or a stable sprain? One of the things I'm going to do over the course of this talk today is present some literature. We're not going to be doing sort of a journal club because that definitely didn't happen in the doctor's lounge. But if anybody wants to point their iPhone or Android camera at the QR code that's up on the left of the screen there, it'll give you an option to launch your browser and get this paper. So if you want the reference, it's up there. But what's really interesting, this is a nice review out of AJR on musculoskeletal sonography and its dynamic nature and how you can use it for multiple things. In this case, they're kind of highlighting shoulder impingement syndrome on the first pages, but they really go through a nice range. It's a nice review article. What's fascinating to me about this, and then we'll move off of musculoskeletal, at least for now, is if you look really closely and squint at the bottom, this is from 2007. So 15 years ago, musculoskeletal sonography was being published as a review article because it was so well explored for multiple applications. And John knows that that for me, one of my fascinations is knowledge translation. And that from the time we know about something to the time we start really implementing it in practice is really kind of absurd that it takes as long as it does. And 10 to 15 years, probably closer to 15 is about the average. So now's the time. We're 15 years out from having reviewed this. It's probably time we start using this for taking care of patients.
Yeah, it's interesting. I think the guidelines for rotator cuff are ultrasound first, but I don't think the majority of people get an ultrasound first. So it's pretty interesting. So 15 years, we're about at that point now. Now everybody's going to start using ultrasound tomorrow because we've crossed that threshold and the tipping point, right?
Absolutely. Absolutely. All right, let me go ahead and get us back going. I was checking the QA panel, and we'll wait for some other questions to populate before we run through some in bulk. So let's go back. We'll move on to the next case.
This is a quiet doctor's lounge. There's not a lot of conversations.
I know there's not as much bickering and as I'm used to in the doctor's lounge, but we'll get there. We're just getting warmed up.
Before this is all over, please somebody argue with Mike because that's the best part.
Oh yeah.
I see somebody disagree.
Well, here's an opportunity for you to shine, John. So as John mentioned, he's a vascular surgeon by training, and this was a case that one of our users submitted from Brazil, I believe, although if I'm incorrect, please forgive me. It is, we'll see from the images that we're in Spanish language on the presets. So apologies if I got that wrong, but I think it was Brazil. But this is accidental puncture of a brachial artery for hemodialysis. Is this something that happens, John, where you puncture the brachial artery by accident when you're trying to dialyze someone?
Well, I've never punctured an artery accidentally in my entire career, and if you believe that, just ignore the fact that my nose is growing. No,
yeah.
It's actually interesting how often actually accidental punctures of arteries actually occur, and even more for the bane of vascular surgeons' existence is the way dialysis, either fistulas or access, get tortured during punctures, and so I'll be very interested to see this case unfold in front of us. I don't know what you're bringing up yet, but it'll be one that I'm sure I'm used to have seen one or two times before.
Well, this will either be the first time that we do Doctor's Lounge like this where you haven't seen any of the cases, or the last time, or both. So here's the image that we're taking a look at, and brachial artery. I think we're here with brachial artery. I'm not sure if this is part of the fistula which would make me wonder if that was part of the fistula there, just that communication.
Yeah.
But then it does look like we've got something else popping up over here, with this traditional sort of yin and yang flow inside of this focus here. It's more irregularly walled. There's some fluid around it. And this area here is what I'm talking about. We've got sort of bidirectional flow in here with what looks like a little narrow neck between the brachial artery and this structure. So, John, what do you think happened here?
Yeah, this is the lovely pseudoaneurysm, if you will, from a puncture site that in the old days, I'll go way back, we actually used, this is the crazy part. I love the way medicine evolves. So in the old days, and we see these a lot from percutaneous procedures done in the femoral artery, where you'll see this and you're trying to determine whether you have a hematoma or a pseudoaneurysm. You see these little necks and the to and fro flow of really the tip off that's what you're dealing with. In the old days, we used to operate, and then we went through a period of time where you just did compression with ultrasound, at which point the patients were very angry with you. And then the evolution of this today, it'll be interesting to see how they manage this one, is we actually started doing thrombin injection into this under control, under ultrasound guidance. And what was always fascinating was if you read the bottle of the thrombin, it says not for arterial injection, which is essentially almost what we're doing is a controlled, if you will, non-arterial, but close to the arterial injection, but turns out to be incredibly effective at controlling these and avoiding an operation. So be interested to see how this one turned out and how they managed it.
Well, let's find out. Pseudoaneurysm. I'm not going to try and pronounce it in Espanol because I'll probably have a horrible accent. But yes, I agree that that's the diagnosis, and they go ahead and treat this one with compression. And what's really cool about this in my mind as a non-vascular surgeon, but certainly as someone who's dealt with arterial bleeding a lot over the course of an emergency medicine career, direct pressure certainly is the way to go for most arterial bleeding. And I love the fact that you can do it dynamically with ultrasound. So you know where the aneurysm is, you're putting the pressure, the pseudoaneurysm, you're putting the pressure directly over that area and collapsing it. And you can see that you're compressing it adequately with ultrasound guidance over the course of the treatment. I got some communication through image submission for this case, and they held pressure for 10 minutes, went ahead and relaxed the pressure. And here we are again after 10 minutes of compression. And I don't see any flow into the structure. Looks like we have a successful treatment of this pseudoaneurysm that occurred with an accidental arterial puncture.
That's very cool. And the factors actually that contribute to the success of direct compression always are, first of all, where is it? In the femoral, sometimes, particularly if they're up high, it's really hard to get direct compression over it. Even though you struggle, you're kind of squishing everything when you do it there. The second thing is, are they on any anticoagulation at all? That's another big factor with this. And then the third one is how big is the neck? If the necks are huge, this really doesn't work very well. But if you have a nice little neck, and you can get good direct pressure and they're not on anticoagulation, it's incredibly effective. And the downside is for inpatient surgeons like myself, 10 minutes feels like eternity when you're holding pressure on it. So, but as we all said, that's what interns are for, right? Give the first or second year residents, say, hold this, keep pressure on this, I'll come back and check on you. But this is a great case. This is a great case.
I feel like that was the same flavor of role that I had in every operating room experience that I had in my first couple of years of residency in medical school. So that sounds painfully familiar. Retract, pull here, pull harder. Right. So safe to say, we're not doing a comprehensive review of the approach to treating pseudoaneurysms, but from what I learned from you here, it sounds like first step for you would probably be a thrombin injection. It's just fast, it's easy, you're doing it under guidance. And then if that failed, either compression to see if you can get away with it, and if not, you're going for a percutaneous or a surgical approach to fix it.
Yeah, and there are some people would say really tiny ones. Let's see if they will thrombose on their own. I guess it depends on how acute and where they're presenting, what they look like. There's some that actually will, because that to and fro flow is not some there. So it depends on how quickly afterwards and how big it is. I think the secret with direct injections, you actually see it. You got to be very careful doing it. You don't want to blast thrombin right into the arterial bed. As long as you're careful and have a nice gentle touch, it actually works incredibly well. And you trickle it in there and watch it actually just thrombose right in front of your very eyes. It's a very cool, actually, procedure. It's kind of fun to do.
Yeah, this is just another example of that I thought illustrated the flow really well. So this is a different patient with a femoral artery pseudoaneurysm after femoral artery access for percutaneous coronary intervention. So came back into the emergency department about maybe 5-7 days afterwards, with some pain and swelling in their groin. And this is one of the reasons why everyone who gets a cath gets told to check the groin area, look for swelling, and look for bruising. And this one was treated in the cath lab. Actually, I think they did directed thrombin injection under ultrasound guidance for this one.
I mean, I think it's worth one thing to point out here too, and it's going to be intuitively obvious to everybody here that's using point of care ultrasound, but from the patient side of this, sitting there, then okay, oh, you got pulsatile flow in the groin, or feels like it. I don't know whether it's a hematoma or pseudoaneurysm. My physical examinations, I could guess, but I wasn't always right, and you clearly had to get an ultrasound. And so you're in the emergency room or something, and you got to wait for the tech to come. And you end up sometimes in the emergency room waiting a long time for that to actually happen, which then makes the decision of what therapy is going to be done. If you've got a point of care ultrasound at your disposal, you make this diagnosis instantly. I mean, your clinical decision making happens within an instant. With plopping that probe down there, you know exactly what's wrong with them and exactly what you want to do. And I think the waiting time for ultrasound in emergency room sometimes can be a really long time. And these are the kind of things that are incredibly important to remember. And whether you're a cardiologist seeing somebody back in your office after procedure, the primary care doctor who actually goes back in to see his doc because I have pain in my groin from the stick, and they see them as a first point, or vascular surgeons to do procedure. This is so important in how to do this because it just makes care so much faster if you do it this way.
I am going to hit you up with some questions from the crowd, John. Number one. I like this one. Not related to the cases, but still, when are you planning to release the butterfly worldwide, John?
Tomorrow. No. So worldwide, every country actually has its own restrictions and limitations to actually getting the device out. And we're moving our way from country to country along the way. We're 23 and expanding all the time. And as the team grows, we're trying to do the same thing. So I can't give you a specific date for every single country, but I know we're expanding pretty significantly over the next 6 to 12 months. We have Bill Porter on our team, actually heads up our international expansion. And so if you want to drop us a thing in here and tell us what country you are and maybe and request into Butterfly, we'll try to give you some idea of when we're coming to a theater near you, as we like to say. But it's a matter of our team growing, the process growing, and then having the right regulatory. Now that one I won't know the answer to, but I promise you that I will look. But that's a good question.
Yeah, I love it. It's fantastic. So we were, for everyone who's posting countries in the chat, we have these are recorded, so we can forward these to our international team and work on getting you an estimation of when we can get this available in your neck of the woods. Some other stuff coming up. Heck, more coffee from Andrew. Yeah, that'd be great if we could have coffee the next time. I'm not sure how good it's going to taste to people on the other side. You're gonna have to get your own. And then can you measure left ventricular ejection function on iPhone/iPad app? So we do have a product in Australia, New Zealand, and the EU that does that on the iPhone/iPad. And I can say for the US, stay tuned. But not currently in the United States. What are your thoughts about POCUS and meaningful use? That's a great question. So just because you can do a test doesn't mean you should do a test. And I think that'd be the most terse summation of my thoughts on POCUS and meaningful use. To me, and I'd be interested to see how you approach this, John, but I still have what I think is a very old school traditional way of looking at diagnostic testing, which is if it's going to change my management of the patient, the result of that test, if I anticipate there's a significant likelihood that it's going to change my management, I'm going to do the test. If I don't think it's going to change my management, I'm not going to do the test. So if I'll give you a straightforward example, if someone comes in with a swollen limb and I'm wondering about whether it's a deep venous thrombosis or a cellulitis or abscess, I'm certainly going to look at that patient with point of care ultrasound because those are really different treatment pathways for me, depending on what the diagnosis is. Um, on another hand, if someone has vague diffuse abdominal pain and a history of a cholecystectomy, conceivably I could look to make sure that they don't have choledocholithiasis and a stone in their common bile duct. But the likelihood is so low that just because I could look, I'm not going to look. And more controversial, if I have a hemodynamically stable trauma patient with blunt thoracoabdominal trauma who's oxygenating fine and looks well and their abdomen's soft on exam and their vital signs are normal, but let's say there's ecchymosis over the seatbelt distribution, that person in my clinical practice is going to get a CT scan because it's more sensitive and more accurate in that setting of a stable blunt trauma patient. And doing a fast exam in that case, I don't really have any qualms about someone doing it for educational purposes if they're learning and getting their skills up and they want to correlate it to the CT. But if I do that scan and the patient has a positive fast, they're going to get a CT scan. And if to further delineate the injury and see how it can be managed. And if they have a negative fast, they're going to get a CT scan because the fast isn't sufficiently accurate to exclude, considerable blunt trauma in a stable patient. So since I'm doing the same test afterwards either way, I'm probably not going to be doing a point of care ultrasound in that case. I'm not trying to pat myself on the shoulder, but I think I've done enough fast exams that there's not much educational value in me doing it at this point. So that's sort of how I think about meaningful use in POCUS.
So maybe I'll just argue just for the sake of arguing and just because
Let's do it.
Need to do it anyway. I struggle with this one. I think it's pretty easy and straightforward. You're going to bill for things that meaningful use matter, and I think that's why the rules are in place so we don't abuse them. But let's use the example of your trauma patient. We're going to order a CT. There's a bunch of CT scans that are ordered. The patient's hemodynamically stable. I'll turn to the nurse and say the patient needs a CT, but there's not urgency because they're stable. As opposed to you do your quick fast exam and go, he may be hemodynamically stable, but there actually is blood inside the abdomen. So my index suspicion goes up and said, you know what, move him up the list. I think that one should be done sooner. And obviously that's a hypothetical, but the way, and my thinking around this is tough because it's evolving. Listen to their lungs and, am I going to know a lot more if I look real quickly? I mean, God, if there's anything you've taught me, it's certainly the lung exam and how powerful that is. I listen for crackles all the time, but are they wet? Are they dry? Is it pneumonia? Is it COVID? Is it congestive heart failure? Maybe I'm going to order chest x-ray anyway. You probably wouldn't because you can do it all with that. But if I get a clue and it's fast and it's right in my hand to do this, almost every part of my physical examination, as I get better and better at ultrasound, is better if I'm looking and not just listening. It's better if I look at the heart, I'll be surprised with what I find. It's better if I look at the lungs because I'll have better information. And even in your case, it's better if I look at the abdomen. Now, should I bill it or not? That may be a different question. But as the world of medicine evolves and point of care ultrasound becomes a critical part of how we evaluate people, and I realize I'm shaking a stick at the snake of, oh my God, now that payers are going to say it's part of the routine physical examination, we're not going to get paid. I know that that's a controversial subject, but I don't want to estimate the power of what ultrasound could do. If you remember, and we've got those primary care papers, and they're a little bit skewed, but when you use it, particularly when you think about using 50% of the time, in a number of those papers, they changed management, changed diagnosis, and had a dramatic impact on referrals. And so I think a lot of it depends on how good or bad you are at actually doing it. And it's also, how in which you use it inside your practice. Let's just separate the billing and the economic part from just the clinical part. There's such power in imaging at the bedside. I'm torn with what the right answer to this question should be.
Yeah, and a post from someone else about meaningful use really being about EHR use and not about appropriateness of testing and billing. We're keeping it clinical as much as we can here, since one of the benefits of walking into the doctor's lounge for me was just getting to talk about the clinical stuff. But I think these are all. It's a fascinating area to talk about. I've definitely used that. I used to work night shifts in a critical access hospital with 8 beds and 3 nurses and myself and maybe 2 other doctors in the county. And on the couple of occasions where we had multi-trauma events, a car turned over on the freeway, I would definitely do a fast exam on those patients because, to your point, triaging them of, if one of them has free fluid, they're going first. even if they're all stable. So I agree with that point, particularly because I've lived it. All right, cool. Let's we'll pause from questions for a minute. We'll look at some more stuff. This is a case with a patient presenting to the emergency department with pain in their forearm after a recent admission to the hospital. And we go ahead and take a look at the forearm in a transverse view. And we're in a vascular setting here. We've got this hyperechoic focus here is bone with some posterior acoustic shadowing. And there's this mixed echogenicity circular focus here that you can kind of track up and down the arm. And in the setting of a recent hospital discharge that almost certainly involved peripheral IV placement for this patient. What do you think the diagnosis is here, John?
Is there a nice red streak that goes up the arm as well with this, or is it just a very simple superficial thrombophlebitis that we're dealing with from an IV?
Yeah, I think it's not my case, so I can't tell you, but certainly this would be a great time. Number one, a great example of why point of care ultrasound is so intuitive and special, in that you just ask the patient where it hurts, you look at them, you're integrating their recent history, and before you put the probe on, you're probably thinking this sounds like a thrombosed superficial vein, and go ahead and put the probe on. This is exactly what it looks like. You have a dilated vein here. There's mixed echogenicity within it. This is a thrombosed superficial vein. You'd want to track that up proximally and see, does that extend into the basilic vein? Does it extend into the axillary vein? Is this actually an upper extremity deep venous thrombosis? But in most cases, these end up being localized and superficial. And the treatment of these has changed so much over my career.
Just I was going to ask you, how are you going to treat this, Mike? I love
this. Used to be, warm compresses and NSAIDs, and you're going to be just fine. And the areas that worry me here, I'll extrapolate from the literature I know reasonably well up to date is around the saphenous vein. So greater saphenous vein is a superficial vein, but if you have thrombosis within 4 centimeters of the saphenofemoral junction, or if you have a greater than 10 or 11 centimeter length of thrombus in the greater saphenous vein, American College of Chest Physicians' most recent guidelines say you're going to treat with a course of anticoagulants beyond just NSAIDs or aspirin. So, and those will be typically the sort of newer novel anticoagulants. What do you do for an isolated upper extremity superficial venous thrombosis? I always wonder, are they sick? Is it infected? Is this a thrombophlebitis? Is this something I need to be worried about putting the patient on antibiotics? Those patients tend to be more toxic appearing and have other systemic signs of infection. And then, do I need to anticoagulate? And honestly, this is one of the times that I'm happy to say I don't know, and I would be going to recent society guidelines and doing a quick check. I'd let the patient know, hey, it looks like this vein's thrombosed, and I want to go. We used to treat these with NSAIDs, but there's a lot more indications for the oral anticoagulants these days. I'm going to go look up current recommendations. So I don't know the answer. I'm not sure if there's a length of thrombosis cutoff or a proximity to the deep veins of the upper extremity that would tilt you towards treating more aggressively with anticoagulation here. But I know how to look it up, so I would.
I think what's really interesting, if people want to throw in the chat, if you will, how you would treat this. I think there's a couple of ways I look at these a little bit differently. I'm somewhat uncomfortable with where they've gone with the use of the anticoagulants, just because I'm so often seeing the complications of them, even in short term. Plus the fact that, you watch venous centers across the country who are purposely creating thrombosed superficial veins all the time. And how close they get to the saphenofemoral junction in that situation is obviously a kicker in the equation. Part of what used to guide my decision making was really around, if I had an inciting event, like if you stuck an IV in it and it was there for a while and then they thrombosed, I was less likely to use anticoagulation than someone who just developed this spontaneously. The hard part for me were always those patients that had redness in their arm, they got an elevated white count, they may have a low grade temperature, and now they're saying, you need to go take this out because it's a septic vein. And the last thing you really want to do as a surgeon is go take out an acutely thrombosed inflammatory vein, because first of all, it's no fun. Second of which, almost always you get in there and there isn't an abscess in there, and you go, why the heck was I doing this? So those are always the tough call. And I can't believe how often actually I see people actually put these folks on antibiotics too, when you're wondering, do they really need it? So I think these are, it's so funny. You think about this as such a simple little thing. I think it's hard. They're complicated. And I don't know that it's patients got appendicitis. I know what to do. It's not much of a debate. These ones are kind of
actually now there's a debate.
Well, yeah,
about
now they've
too,
messed
John.
it up. Now we're going to watch it.
Now there's antibiotics for appendicitis, and so things used to be simpler. Just cut whatever it was out. And
I just want everyone to know, every surgical intern on the planet is now complaining that appendicitis is not an operation anymore. That just is such injustice to training.
I lamented that a little bit when the first patient I took care of for appendicitis was treated with a antibiotics only course, and they actually at least during that hospital admission did tremendously well. But probably not with the within the scope of Doctor's Lounge, but some recent evidence that there's definitely a higher recurrence rate in patients treated with antibiotics only for their first episode of acute appendicitis. I'll go on record right now and say it depends on whether my house is under construction after a flood, like it is right now, on whether I would take antibiotics or take the surgery. I might do antibiotics right now because I just don't think I can handle a post-op course, but then I would plan on getting it again and getting my appendix out the next time.
Well, I will put my vote in. If I have appendicitis and I show up in your neighborhood, any of you on there that are out there in land, please have my appendix taken out. Okay, just take it out.
Done. We've all heard it here. All right, I'm gonna try and do something here, and we'll see if it works or doesn't work. But we had a webinar around vascular access, and there was some requests for some live scanning tips and techniques, and we didn't get to it. We weren't really set up for it on that last webinar, but I promised we would cover it at some point, and I don't like to say I'm going to do something and not do it. So we're not going to take up the rest of, we're doing good. We've got about 20 minutes left, but we can run over a little if people are still on. So I'm tourniqueting myself here, and then we're going to try and do this live scanning. We'll see how it works. And if we can get some, anybody who's interested in the chat to let us know if this was useful after we're done, that'd be awesome, because it'll inform whether we set it up again next time.
I'm getting nervous. You just put a tourniquet on your arm.
Well, so
what are you going to do?
We're going to be doing some venous scanning as if we're going to do a peripheral IV. We are not, yes, Dorian, I see your post, not going to get bloody. I am unarmed. I have nothing sharp around me. I'm not going to stick myself. I have been known to do procedures on myself for educational purposes. At one point, I did a nerve block on my tibial nerve live at a conference, and didn't pass out, but almost passed out. So I'm trying not to do that anymore. But I'm going to use our teleguidance functionality to live scan with you guys. And John, tell me if you can see that browser.
Yeah, we can. It looks good.
All right, fantastic. So basically, this is the screen that you see as the coach in teleguidance. So here's the live scan coming from the ultrasound system. Here's the forward-facing camera on my phone that I have propped up here. And then there's actually some augmented reality commands and things that we can offer, but I'm gonna do what I can since I'm scanning myself. So I'm gonna put the probe on my arm, and we'll see if I can get my arm in a position where we can kind of see it okay there. And I may need more gel, but here's a great example. So why is preset so important? So if you're going to do a survey for putting in a peripheral IV, the first thing you want to do is decide, which side you're going to go on to. And then you do want to tourniquet the arm, because it's going to make the veins harder to compress and increase the pressure in the veins. In this case, I can see on the very bottom left of the screen there, underneath the ultrasound image, it says nerve. So I'm in a nerve preset. I'm not in a vascular preset. Now, I can still see the vein at the very top of the screen there. And if I press, I can compress it, but it doesn't look really clear to me. And I can go ahead, I'm actually going to change it just through teleguidance because this lets you change your user's presets to vascular access, so I don't have to pick up my phone. And then I'm also going to go ahead and just change the depth a bit so that we're really superficial. So we're in the right preset now, and we're really superficial. And I'm gonna go ahead and just increase my gain a bit. And I think I'll just do that right on my phone, although I could do that in the depth and gain controls on teleguidance too. So now we've got a nice view of a vein there superficially. And I can go ahead and compress and show that it's venous, it easily compresses. I'm actually just going to add a little bit more gel. There's just a couple of points that I wanted to make that had come up in that webinar.
And Mike, how did you change the depth and gain? How did you do that?
So on the phone, I can just swipe right and left on the screen, or up and down for depth. And if you're coaching someone, you can click into this gain and depth, and you can do it for them if you're coaching them remotely with teleguidance. So there we go. I got a little more gel on that's a little bit easier, and I'm going to orient the probe indicator in a way that makes sense to me. So now I've got the vein centered in the middle of the screen. If I was going to cannulate that vein, there'd be a few things I'd want to do first. The first is I want to make sure that it's a vein and it's not an artery. And you can see there's some deeper vessels over here overlying the fascia. If I compress there, one of them doesn't really compress. And if you really, I may have overgained a little bit. I'm seeing some echoes inside the vessel. So I think that I'm just overgained. Yeah, there we go. So here, if I compress, that one in the middle doesn't compress. If you really want to see an artery pulsate, just press a little harder. And it'll get a lot easier to recognize that that's arterial, right? So unless you're planning on doing an arterial puncture, and I could follow this down to the wrist and do a radial arterial line, don't put the needle into the ones that don't compress. And then on the superficial side, a light touch will help a lot. If you just have a little bit too much pressure, you see how I'm collapsing that superficial vein. If you just ease your pressure up, you'll get a nice big target there to go after. All right, once you've identified your target, and I actually like where this target is, it's in the mid forearm. It's not in the antecubital fossa. It's not going to give the patient discomfort while they're bending their arm and moving their arm around after the catheter's in. You could also go sort of up here to cephalic, and I don't have a lot of gel on there, but yep, there's a cephalic vein, compressible.
I think one of the other things to note, Mike, while you're doing this, if you actually, and well, it's not absolutely key. You look at your arm, you can't see that vein. I mean, so this is not like, you plop the tourniquet on the arm, there's this big juicy cephalic vein going up the arm, you're going to stick. This is really only visible by ultrasound. I don't see that on the surface of your skin. So
100%.
Really, yeah.
Yeah, 100%. This is a vein that no one has ever tried to stick for me because I have palpable veins in other parts of my body, like up in the antecubital fossa. So when I get blood draws or whatever, people always go there, or they go in my hand for the times that I've had surgery. Nobody can see this vein with the naked eye. The other thing, you can just kind of check your depth and say, is this a good depth for a venous cannulation? So, you see the depth markers on the right side of the screen. We're at 2 centimeters to the bottom of the screen. So those clicks are 2 millimeters each. So we're basically just around 2 millimeters under the skin to the superficial surface of this vein. That's a great depth. You really don't want to be going after, in my experience, you don't want to be going after veins that are more than 1.2, 1.3 centimeters under the skin. It's just a sharp angle to take, and often you won't end up with as much catheter in the vein when you're done, and they're more prone to dislodge. So I'm generally looking for something a centimeter or less. There is some literature on this. For anybody who wants to Google, Nova Panabianco from Penn published a paper about the appropriate depth for peripheral IV cannulation. That's an interesting read. And then from here, how are you going to make this most likely to be successful? Well, I'm not going to talk about the cannulation aspect, obviously, because I'm not a glutton for punishment that badly. But there's 2 things you could do from the ultrasound standpoint. One is you want to make sure that you're actually in line with the vein. So if I start to go up and down my arm, you can see how the vein's moving left to right on the screen. And that just tells me I'm oblique to the course of the vein. I'm not really transverse to it here. So there's a couple of things you can try. First, you could just guess and rotate the probe a little and then slide up and down. And in fact, that's a really good guess, because that's pretty much the trajectory of my vein across the forearm. The other thing you could do is just turn and rotate the probe into a longitudinal view. And when you have a good longitudinal view, the vein should be open on both sides of the screen. That tells you that you're really in parallel to the vein. You got a nice look at a venous valve right there, actually, on the right side of the screen.
That's really nice clarity. It really is.
So from here, now that I know that this is the trajectory of the vein, because I'm seeing the whole vein, oops, I slipped off because I was looking at the screen, seeing the whole vein in long axis, I can just look down at my arm and go, okay, well, it's 90 degrees to that. And now if I slide up and down, it's staying centered on the screen. So that's sort of how I get the right path, because as you start to insert the needle, you're going to see the needle tip in the soft tissue superficial to the vein. You're going to move the probe away, advance the needle, move the probe away, advance the needle, move the probe away until the needle tip is in the lumen and beyond. You just want a fair amount of catheter in the lumen, but it's really a challenge to do that, and you're going to be unsuccessful if you're oblique to the vein, because you're going to start off here, put the needle in, slide, put the needle in, slide, and your target's moving away from where the needle's going. So you definitely want to make sure you get that nice perpendicular axis, and that you're running up and down the real course of the vein, not up and down the longitudinal course of the limb. So that'd be one thing. And then the last thing, and I'll take us off of live scanning, is depth. You know, if you're going to adjust three things only on an ultrasound system, it should be the preset, which we already kind of talked about why that was important, the gain, which we already adjusted, and the depth. And in this case, I don't need 2 centimeters of vision to get into this 2 millimeter deep structure. So for me, I would want to you want to make all the target as big as possible. So let's take the depth down to 1 centimeter. And now you've got your target right in the middle. You can work on getting your angle right. And now I'm a little bit further up. There we go. Right now you've got a really great look at live scanning on a video screen is a little bit of a challenge. So thanks for bearing with me, people. But now you've got a really clear image. We can see that there's actually, even in transverse, you can see the valve is right there. So we're probably going to want to go a little bit further away so we don't get hung up on the valve. And now we've got this fabulous target to look at. We can go ahead, compress, make sure we're still happy with it. And now you've really set yourself up for success, as opposed to just kind of seeing the first anechoic structure you can that collapses and sticking a needle in it and getting frustrated when you don't get the IV the first time. So maybe more to come in the future on that, but we'll stop live scanning and I'll get this tourniquet off my arm for now.
Any other features, Mike, that you use to put in IVs, or do you do it just in the manner you just showed, or do you throw in any other little bells and whistles at that?
Yeah, I usually do it in the manner that I just showed. I feel like that's a leading question, and we do have a couple of
leading question,
and we do have a couple of capabilities on the device that frankly I haven't explored whether they're functional in teleguided, so I didn't go into them. But the two other things that I have used for vascular access are biplane. So we have this phenomenal ability to view a structure in both planes at the same time, which I really prefer for something like an arterial access or a central venous catheter, just because the stakes are so high for getting into the wrong spot in either. And then needle guidance or needle viz, where you'll actually get sort of a blue highlight over the needle. So if you're having trouble with needle visualization, I use that a lot in musculoskeletal procedures. So like bursal injections, just getting the exact location of that needle tip, or for regional anesthesia for nerve blocks. Again, nerve blocks are they're so much more successful in my experience when you're exactly where you want to be inside the fascia, separating the fascial planes and surrounding the target nerve with anesthetic, and knowing exactly where that needle tip is really useful. So I do like needle viz and biplane for regional anesthesia as well.
Yeah, and I think the literature is pretty clear that the onset to action and the duration of action is significantly better when you use ultrasound guidance and get it in the right place. So I think those are pretty helpful tips. Well, you got some questions that are lined up for you, Mike. You want to take a peek at them and see what you would like to fire back?
Sure thing. And I've got a couple of comments that I'll answer too. First of all, Trevor, thanks. Glad you enjoyed it. Dorian, do I often use POCUS for peripheral vein cannulation? Usually nurses are quite successful. So let me be clear, this is a great meaningful use question, right? If you put a tourniquet on and a patient has great veins, there's no reason for you to be doing it with ultrasound guidance. In patients who are difficult venous access patients, and I work in Portland, Oregon, where we have a large population of injection drug users. I've worked in places where we had a large chemo active malignancy population where the veins are very challenging to get. And in those cases, it's transformative. It's from a patient experience standpoint alone, it's worth it. From a ED throughput and resource utilization, not having a nurse trying 3-4 times is worth it. But from a patient experience alone, getting stuck 5 times to get your IV versus getting stuck once, maybe twice, is really transformative. So I definitely walk the walk for peripheral IV access with ultrasound
and I would add to that, Mike, because I think, and I will certainly say I'm one of those people that underestimated, quite frankly, how often people were getting multiple sticks and how often kind of crappy veins were just what people could get. There's been some interesting things that we've seen in the literature now that if you can get the right vein, I mean, kind of the goal really for people coming, 1 stick, 1 vein, entire hospital stay. That's what you'd like to do. And that's hard to do. I mean, you got the 24-year-old weightlifter, that's easy. But a lot of the folks, it's really tough to figure out, and a quick assessment with ultrasound to say, which is the right vein for me to go in, not a crazy idea. So I think this is, again, one of those things that my thinking is evolving over how frequently we should be using it.
All right, I'm going to rattle down some questions, and then we're going to cover maybe 1 or 2 more cases real quick. So I'm not going to call out your names, everyone, just for the purposes of speeding through. What are my thoughts around nerve blocks with Butterfly? I've used it a ton myself. I know a bunch of anesthesiologists who use it and love it. Do you see a future for POCUS with EMS? If they can't get an IV, they do IO, but this might be nice for long transport times in rural places. 100% agreed. The videos of like the people who make IO needles getting IOs to show that it doesn't hurt. I've always looked with skepticism on those. In a sick patient, IO if you can't get an easy IV. And I 100% agree with that. I don't want people fooling around with ultrasound guided lines when you have a crashing unstable patient who you can't get venous access. You should be getting an intraosseous line in those patients. But long transport times, stable patient who you want to get an IV in, it's a great application. And there are a number of EMS organizations in the country and outside of the country using point of care ultrasound on board their ground and air transports. How long of an IV catheter would you need for peripheral IV access? I'm assuming generally 2.5 centimeters or at least 1.88, which is one of the common lengths. You don't want to use a standard length IV because of the fact that you're going deeper through skin. You want to have catheter inside the vessel. So that's a great question. You do want to use a long IV catheter. Someone asked how much how many millimeters do the markers represent? If you just look at the centimeter marks and see how many hashes are between them, it changes with depth. So it will change as you adjust your depth. And in that case, when we're down at 1 centimeter, we've got 2 millimeter hash marks. But if you're at 30 centimeters, I'd have to pull up the probe and look at it, but it's probably just each hash mark is a centimeter. So you just need to look at the numbering. Do I ever do temporary internal jugular cannulation with a regular IV? I have to say I don't now. It's published. I think I've published on it before. Back before IOs were really available in a drill format, when you had to actually use like a Jamshidi needle and like screw the needle into the bone. I definitely use this for difficult access in unstable patients. Now an unstable patient, as I've already said, I'll probably go to IO. So, but there's literature on the rapid IJ, or there's another term for it in the literature, but this concept of just placing a long catheter in the internal jugular to start treatment and stabilize a patient and then move on to getting more definitive access. So it's certainly out there. Are you able to do biplane imaging when you do teleguidance? I don't know, because I haven't tried it, but I don't think so, but I'm gonna have to put a pin in that one, and next Doctor's Lounge, I'll know the answer. Great demonstration, thank you. Any tips on subclavians with Butterfly? Would you use short axis or long axis? Let me see if I can do this real quick, and then we'll come back here. So I'm back in teleguidance, I think, and I'm going to initiate a phone call from myself to myself, which is really cool, actually, that you're allowed to do that. And Let me just flip my flip back to a front-facing camera. And I have gel around here somewhere. There we go. And let me get a little more depth. So for subclavian venous access, I may just ask you guys to look at the lower corner of the screen for where I'm going to put the probe, but I'll actually put the transducer right on the clavicle. So there's clavicle on the left of the screen. And from here, I'm going to need more depth than that. So I'm going to swipe down. And if you just slide along the clavicle out laterally, that's probably my subclavian vein there. I'm going to just Valsalva real quick.
Can you tip the camera up a little bit?
So we'll see if I can do it like that. So we're right here. And I'm just going to Valsalva here. Yeah, which isn't really changing it because I'm sitting upright, but that's my subclavian vein right there. And when you're laying flat, you can actually cannulate it right as it goes under the clavicle and get what's really a true subclavian. If you come, that's pleura down there, there's artery in long, and then back to vein in long. You can do this in a transverse view too if you want. So you've got artery on the left there, vein on the right, and you can get it right as it emerges from the clavicle. So certainly possible. I've done plenty of subclavian lines with ultrasound guidance, and I like it. I'm less of a fan of the original descriptions of subclavian venous access with ultrasound, which were really kind of out here, and they were basically axillary vein cannulations. But if you go right under the clavicle, that's a subclavian venous line. And there's some prospective longitudinal studies on subclavian venous access with ultrasound guidance versus without, like comparative RCTs, and pretty cool. Looks like there's definitely a better overall success rate and lower complications. And let's see, so yep, ultrasound guided technique more frequently successful at the first attempt, required less attempts. In this one study, there's other ones that show that fewer complications. So definitely something worth doing. All right, we're gonna try and stay mostly on time and maybe run through one more case. So that was our live scanning that we did already. And just to mention that, obviously we were talking about superficial venous thrombosis, but ultrasound for the detection of deep venous thrombosis and point of care ultrasound for it is a phenomenal tool. This is a patient with a femoral vein thrombosis. We can see not collapsing with pressure. The one thing I'd say here is, as soon as you identify that it doesn't collapse with pressure, you probably don't need to keep putting pressure on it as you're doing your scan. You've made the diagnosis at that point, and nobody wants to be the person who breaks off the clot and sends it. It's extremely unlikely, but there have been case reports. So once you get compression and you see that, that vein doesn't collapse, you now see some echogenic thrombus within the vein, you're done. You don't have to press. You can continue your study to see how far it extends. You could do color if you want, but I would stop compression at that point. One more study, if people want to pull up one of my favorite names of a study, Hocus Pocus, hospitalist operated compression ultrasonography, looking at hospitalists doing point of care ultrasound for DVT, and sensitivity was 100%, specificity 95.8%. So you think about how long it takes someone to get an ultrasound, how time sensitive this diagnosis can be, and this is really something that can add a ton of value if you know how to do an ultrasound for deep venous thrombosis. And then I'll wrap up with this case from a friend of ours in Chicago. This is a teenager who presented with altered mental status, vomiting, and hypoxia. Challenging case in the sense that this is not a well teenager, is a teenager actively undergoing treatment for malignancy. They were concerned about many things, including pneumonia, and in the course of assessing the patient with point of care ultrasound to take a look at their global cardiac function and make sure there wasn't a pericardial effusion and see what could be causing this patient's shock, they obtained this apical 4-chamber. Um, and, a couple of things I'll point out. Number one, if you want to improve this apical 4 a little bit, you really want to get the center of the imaging beam right over the left ventricular apex. So you just kind of slide towards the indicator in this case, which would be probably towards the patient's left side. You might get a little bit of a clearer view, but you can see left ventricle, left atrium, right ventricle, right atrium. And there's this mobile hyperechoic structure here that's just kind of bouncing around in the right atrium. And really interesting case. This ended up being a thrombosis at the tip of a central venous catheter, and needed to ultimately, it was adherent to the mitral valve apparatus and to the right atrium, and ultimately needed to be removed with a thoracotomy. High potential for morbidity, mortality if that's going to dislodge. That's a pretty giant clot that could turn into a fatal pulmonary embolism. So a really phenomenal example of just you don't know what you're going to find. In this case, you're looking to answer a focused clinical question: does this patient have a pericardial effusion? And it's great that you can use POCUS to answer that question, yes or no. And in this case, there's no significant effusion. But knowing what normal looks like can go a really long way, because sometimes you're going to find things that were unexpected, and being able to recognize, I'm not sure what that is. Maybe it's a thrombosis, maybe it's a myxoma, maybe it's something else. Let me order a comprehensive echocardiogram and get a TTE done for this patient right now, because whatever that is not supposed to be there. And let's get some additional resources mobilized for that patient. And just on the same note, one more case, I lied. Fever and a history of injection drug use. Again, this isn't generally part of our point of care questions. Does the patient have a large mobile vegetation on their anterior mitral valve leaflet? But no effusion, generally normal contractility in this view. And yet you just made the diagnosis of endocarditis in a febrile injection drug user in seconds by putting the probe on and seeing a mobile echo density on the mitral valve. That's pretty significant in this case, at least like half a centimeter in size. So just a plug to keep your eyes open. I mean, I don't think that, POCUS exam should substitute for comprehensive exams. I think when you have a focused clinical question, that's where POCUS really shines. But knowing what normal is really lets you recognize when something's just not right. And it doesn't mean you're going to stop there and, admit the patient to the hospitalist and get 3 sets of blood cultures and, be done. You're probably going to go ahead and get 3 sets of blood cultures and start some antibiotics and admit them, and order a comprehensive echo to see if there's other valves involved, or if there's significant, regurgitation or other hemodynamic issues going on that you want to be aware of. So it's one big continuity of care, from assessment to POCUS to additional studies if needed. But I thought that those were 2 really cool cases of unexpected findings during cardiac POCUS.
And I think, Mike, you made the point, but it's worth really emphasizing. We get caught up all the time because I want to see pathology. I want to see something cool. Let me see the abnormal stuff. Really honing your skills on recognizing normal. It's the value of doing study after study after study. You get used to seeing normal, and the better you get at it, candidly, the less quality the normal has to be for you still to recognize that it's normal. I think that's a key skill that we often underestimate when we're starting to learn new technology. If you can nail normal, then you may not know exactly what's wrong, but it's not right, and you can get a formal study, which is where POCUS can really shine for you. It's accelerating the need for those other things. And certainly, if you're stone cold, absolutely sure it's normal, well, then you don't need anything else to do in that situation, which is really great value as well. I think those were great cases.
Well, and it's one of those one of the underappreciated things when you're just starting off with POCUS is that normal's harder. Almost every abnormal finding with ultrasound is associated with fluid of some kind. So like a dilated cardiomyopathy, the heart's big, there's more fluid. A pericardial effusion, a pleural effusion, ascites, all of these things are easier to see technically because you put the probe on and water, blood, whatever bodily fluid conducts the ultrasound waves so well that you get this crystal clear picture. It's harder to get really great exams when they're normal, but not prohibitively harder. And if you can get good at that, once you know what it should look like, and you have what I like to call this anchor image in your mind of sort of what do I expect to see when I do this exam, you get really good at saying, well, it's not what I expect to see. Maybe it's not one of the things I know that's abnormal. It's possible it's a normal variant, but I think I need some more additional backup here to figure out what I'm doing, because it's okay to say I don't know, and I need to do some more testing so that I can be confident with what I'm seeing and what I'm doing for a patient. So obviously we want you guys to stay in touch. Everyone who's joined and hung on for even past the hour, thank you guys. Feel free to submit interesting cases. You can share de-identified links to your studies, and I'll put them into the presentation the next time at imagereview@butterflynetinc.com. And any topics you'd like to see discussed at a future Doctor's Lounge, just send it to that email and I'll have access. And really appreciate everybody staying on, and looking forward to the next one already.
Thanks, Mike. Great job. And any of the questions we didn't get to, we're going to review all of them. We'll make sure we have them, and you can come back next time and we'll make sure we answer them for you. Thanks, everyone.
Take care, everybody.